morning, everyone. Thank you for joining me this morning, and thank you to Abajo for inviting me to speak this morning. So this morning I'm excited to kind of tell you our experience at VA San Diego of implementing a hematology oncology oral medication management clinic. I have no conflicts of interest and I have nothing to disclose. Again, I'm going to describe some of the strategies we use to implement this clinic as well as provide some observational data of our experience. More than 30% of the medications we use for our cancer patients at VA San Diego are administered orally. As we've heard through several presentations this weekend, that number is probably just going to increase with all of the new medications coming to the market. With the movement of patients being treated from the infusion or inpatient-based setting to the outpatient-based setting, medication adherence is becoming an issue that oncology really hasn't dealt with before. And so medication adherence as well as side effect management can have a huge impact on patients and potentially their outcome for cancer treatment. Close provider follow-up for early detection and management of side effects can then impact medication adherence as well as cancer treatment outcomes. So all of the anti-cancer therapies that we administer are restricted to oncology pharmacist review, which is obtained through a non-formulary request process. The non-formulary request then served as the consult into our medication management clinic. We limited the initial fills to a 2-week supply of medication, and subsequent fills once tolerability and medication adherence were established to 30 days with limited refills. Patients were always assessed in a clinic visit by a physician, which then the medication request was entered, reviewed by the pharmacist, and then the patient was counseled regarding the anti-cancer therapy before being dispensed. Following that initial fill, a pharmacist would contact the patient roughly 7 to 10 days later to assess for tolerability and adherence. Labs could be ordered if indicated and reported to the oncologist. The pharmacist assessed for adverse events and made recommendations for supportive care therapies. And patients were followed mostly by phone, at least monthly, while they were receiving oral anti-cancer therapy. And a note was documented in CPRS of this encounter. We did exclude patients who were receiving any of the IMiDs, and this is simply because of the strict Celgene REMS criteria and monitoring that is already required, as well as capecitabine. We felt that capecitabine is administered more cyclically. We manage these patients through Vista Chemotherapy Manager, and we didn't feel that additional monitoring in this clinic was necessary. We define medication waste as a 2-week supply of medication if a patient discontinued therapy within 1 to 14 days of the monthly cycle. And I calculated cost savings based on the number of weeks of medication saved multiplied by the cost of drug per week. Some of you may recognize this chart. Back in May of 2012, the PBM actually put out a guideline for monitoring these high-cost oral agents. We took that guideline and we tweaked it a little bit to make it our own, and this is just an example of some of the medications, the suggested monitoring parameters, side effects to look out for, and response evaluation. We also developed an Access database follow-up log. This log helped us to manage all of the patients who are on oral agents. It allows us to put in the name, some patient information, the drug that they're getting, and it populates by the earliest date. And we usually set this date about 10 days prior to when the next fill is due. That gives us time to contact the patient, contact the provider if we need to, get a refill in, and mail it out. Mail out the medication, that is. So what did we find? From November 2012 through the end of May 2013, a total of 120 patients were managed by this clinic. We calculated a cost savings, and this is just from reduction of medication waste alone, of $27,981. The bar graph here just shows some of the medications we mostly monitored, with the total number on the y-axis and the actual medication along the x-axis. You'll notice abiraterone, hydroxyurea, imatinib were the most common medications monitored, followed by sorafenib, erlotinib, and everolimus. I do want to point out that hydroxyurea is a bit of an outlier in this group. It's not necessarily a high-cost agent, but we did feel that it was necessary to monitor patients in this who are on hydroxyurea because they are on it chronically. It does have toxicity, and we just wanted to make sure that no patients were, falling through the cracks, so to speak. There were a total of 59 pharmacist interventions documented during the 6-month period, and pharmacist interventions were prompted by either an adverse event or suggested monitoring that needed to be done. Again, the total number is on the y-axis and the event prompting the intervention along the x-axis. Diarrhea was the most common intervention that a pharmacist made, followed by suggested physician follow-up, lab monitoring, hypertension, and medication non-adherence. This pie chart shows the most common reasons for discontinuation. So at the end of this 6-month period, we still had 92 patients actively receiving oral chemotherapy and 28 patients who had discontinued therapy. Disease progression was the most common reason for discontinuation, followed by an adverse event. The most common adverse event was rash and diarrhea that led to discontinuation. The 5 patients in this other category accounted for 2 patients who actually transferred their care outside of the VA after they received a fill of medication, 2 patients who actually got medication dispensed, but then never actually started the medication due to cultural, religious, or personal beliefs, and 1 patient who was hospitalized shortly after receiving a fill and never restarted therapy. So during our experience, we did learn a few things and have a self-evaluation and have some suggestions for this clinic as we move forward. And one is improved documentation across our pharmacy department so that we may better document our interventions as well as ensure that every encounter we have with a patient, that information is documented as well. We're working on a scope of practice for supportive care therapies for nausea, vomiting, diarrhea, constipation, and mucositis. And this is just to more streamline the process of that point of care evaluation. If they have a grade 1 or 2 diarrhea, for example, we can get them therapy, communicate that with the physician, and it can be taken care of right away. And then I think it would be interesting to incorporate a component of physician and patient satisfaction with the clinic so that we can continue to improve our practices. So in conclusion, further evaluation to really assess the economic impact of this clinic is definitely warranted. Again, I just want to emphasize that cost savings is just from reduction of medication waste alone. It doesn't account really for anything else. Implementation of this clinic did standardize follow-up for our patients and increased monitoring for patients who are on oral anti-cancer therapies. Close follow-up and supportive care interventions encourage good optimal medication adherence, and this is important because we're spending a lot of money on these medications and we want to make sure that the patients are taking them. Here are my references. I do want to acknowledge all the people that supported me through this process, especially Brian Dahl and Dr. Seda Kumrani, who are in the audience today.